Hello everyone, welcome back to Radiology Case Videos Flashcard series. Coming to the first case, bilateral parotid glands appears enlarged with cystic lesions within, and this patient is HIV positive and the diagnosis is benign lymphoepithelial lesions. Benign lymphoepithelial lesions are solid cystic lesions in bilateral parotid glands which may show coarse calcifications. They are generally well circumscribed cystic spaces and may show thin rim enhancement on post-contrast images. Ultrasound may demonstrate multiple small septations and small mural nodules. Vascular pedicle may be seen entering the cystic lesion. So the differentials for this condition can be first branchial cleft cyst, which is seen in the region of parotid, Wathin's tumor, Sjogren's syndrome, psilocele, sarcoidosis, and necrotic lymph nodes. Here is the second case where we can see a large cystic lesion anterior to the sternocleidomastoid, which on post-contrast didn't show any kind of enhancement, and the diagnosis is branchial cleft cyst. Because of its location in second branchial cleft cyst, it is generally placed laterally and inferiorly between the internal and external carotid arteries. The angle of mandible is the most common location for these lesions. Generally, they are asymptomatic until they get infected. Ultrasound generally shows cystic lesion, which is sharply demarcated and has posterior acoustic enhancement. CT scans generally show fluid density lesion with thin wall, and sometimes notch sign is seen, which is nothing but the extension of the cyst wall between the internal and external carotid arteries just above the carotid bifurcation. On MRI, T1 signal is highly variable and it depends on the protein content of the lesion. T2 is hyper and there will be no enhancement on post-contrast images until they are complicated. The differential diagnosis for these lesions are paramedian thyroglossal duct cyst, abscesses, necrotic lymph nodes, especially from the papillary thyroid carcinoma, squamous cell carcinoma, etc. Tubercular adenitis, other neurogenic tumors like schwannomas, neurofibromas can also be a differential. Here is the next case. We can see a large soft tissue density lesion in the right carotid space, which on contrast showing avid enhancement. In this image, you can see the external and internal carotid arteries got splayed because of the tumor, and the diagnosis is carotid body tumor. So these are highly vascular glomus tumor and they arise from the paraganglion cells of the carotid body. They are mostly located in the carotid bifurcation, which in turn causes splaying of ICA and ECA, which is called Lair sign, and they can be a part of Carney's triad, which has three tumors. They are extraadrenal paraganglioma, gastrointestinal stromal tumors, and pulmonary chondroma. On MRI, salt and pepper appearance can be seen with these lesions, where the salt part is because of the hemorrhage or slow flow, and pepper part is because of the flow voids. And on T2, salt and pepper appearance is seen when the lesion is larger than 1.5 centimeters. The differential diagnosis would be vagus schwannoma, neurofibroma, glomus vagale, and lymphadenopathy. And this is next case, axial T2 weighted image at the level of fourth ventricle, showing cystic dilatation of the fourth ventricle, which is extending posteriorly and communicating with cisterna magna. This is a coronal image showing the same finding and vermis hyperplasia, and the diagnosis is Dandy-Walker malformation. It is one of the most common posterior fossa malformation. It has a triad where we can see vermis hyperplasia, cystic dilatation of the fourth ventricle, which extends posteriorly, and a large posterior fossa with torcular lambdoid inversion. The torcular lies above the level of the lambdoid, and which is due to abnormally high tentorium. The fourth ventricle generally opens into the large posterior fossa cyst, and this may be characterized by hydrocephalus. Antenatally, we may see enlarged cisterna magna that is above 10 mm and complete aplasia of the vermis. The antenatal scan may overdiagnose if it is performed less than 18 weeks, because the vermis has not yet properly formed. The differential diagnosis, that is the mimics of this condition, are megacisterna magna, arachnoid cyst, epidermoid cyst, isolated fourth ventricle. Here is the next case. This is the T1 weighted image of the ankle, and this is a stereo image, and we can see a well-defined lesion in the calcaneum, which has T1 hypointense component and isointense component to the adjacent bone marrow. And on stereo image, the hypointense component is hyper, which indicates the presence of fluid, and the adjacent isointense component on T1 got suppressed, which indicates the presence of fat. So with these findings, the diagnosis is intraosseous lipoma. Intraosseous lipomas are rare, but they are most common lipogenic tumors of the bone. And the calcaneum is considered one of the most common areas to have this lesion, followed by femur. An important sign is cockade sign, which is well-defined lytic lesion with central calcification. The differential diagnosis is unicameral bone cyst and bone infarct. Here is the next case. This patient presented with painful subcutaneous nodule around the knee, and on MRI, the T1 image showing hypointense lesion in the subcutaneous plane, and on T2FS, the lesion is hyperintense, and on post-contrast FAT-SAT image, the lesion is showing enhancement. This is a resected lesion, and the diagnosis is knee glomangioma. Glomangiomas are glomus tumors and are typically found in fingers and toes and account for less than 2% of all soft tissue tumors. The lesions are generally T1 hypointense, T2 hyperintense, and show homogeneous contrast enhancement. The differential diagnosis for these lesions are angioleiomyomas, neuromas, hemangiomas, and hematomatous lesions. Generally, complete surgical excision is the treatment of choice. This is the next case, where we can see a large pneumothorax and thin cystic lesions scattered in the bilateral lungs. And the diagnosis is Lymphangioleiomyomatosis. This condition frequently affects females of reproductive age group. The main features are proliferation of abnormal smooth muscle-like cells, leading to the formation of thin-walled cysts in the lungs. HRCT generally shows multiple thin-walled round cystic lesions scattered bilaterally without any lobar predominance. It may be associated with tuberous sclerosis and has few extrapulmonary manifestations, which include angiomyolipoma, ascites, and abdominal lymphadenopathy. The differential diagnoses are LCH, which is more common in male smokers, and lymphocytic interstitial pneumonitis, which is associated with Sjogren's syndrome. Here is the next case. In this case, we can see nodular interstitial thickening, which is predominantly seen on the right side, and the mediastinal window demonstrating bilateral hilar lymphadenopathy, and with this the diagnosis is sarcoidosis. The differential diagnosis is lymphangitis carcinomatosis, silicosis, Kohlwerk's pneumoconiosis. Staging criteria is radiograph classification for sarcoidosis, where stage 0 is no abnormality, stage 1 is lymphadenopathy, stage 2 is lymphadenopathy and parenchymal disease, stage 3 is parenchymal disease, and stage 4 is pulmonary fibrosis. This is the last case, where we can see a large lesion with visible wall in the region of pancreas, which is showing multiple air foci, and this is a known case of necrotizing pancreatitis, and the diagnosis is walled-off pancreatic necrosis. It is a late complication of acute pancreatitis, and fluid collections associated with necrotizing pancreatitis can be divided into acute necrotic collections in the first 4 weeks. After 4 weeks, encapsulated heterogeneous non-liquefied material develops, and this is called walled-off necrosis. And on CT, the lesion is generally within or around the region of the pancreas with heterogeneous attenuation surrounded by a wall. And presence of air foci within the lesion indicates infection. The possibility of pseudoaneurysms within these walled-off necrosis has to be ruled out. MRI depicts the internal necrotic debris that favors the walled-off necrosis. And the differential diagnosis can be pancreatic pseudocyst and pancreatic neoplasms. Thank you. Hope this video is useful to you.